Welcome. Thank you for joining me today. My name is Mark Abrams, and I am here to talk to you about migraines. Migraines have been a problem that many patients have had, yours truly included. And I've always been sort of fascinated and sympathetic to these folks because they're somewhat miserable conditions. But they come to us with other manifestations that mimic other conditions that we see: sinus infections, ear pain, vertigo, balance problems, even transient tinnitus and other things. And as such, they become time consuming and sometimes difficult patients to manage because of the lack of good tools to actually prove what's going on. We started seeing a lot more of these since COVID happened, and I had a lot of time on my hands and became one of the patients as well. And my migraines got worse after I got COVID, and I got motivated. And so I learned a trick, a tool that the neurologists have been using a lot, but they can't do it that well because it's literally inside our kitchen, inside the nose, and they blindly use a catheter technique to basically block these patients. And I've always been curious about that technique when one of my good friends and colleagues would send his patients to me after a sphenocath had less than a happy ending to make sure that nothing went wrong in there. But when I examined the nose on these patients and realized all he had was just a scratched septum and a less than happy experience. I explained to them that nothing went wrong, but this sounds like a good idea, and I wondered if we could do the same thing, but that's just not in our area. But it is, and so I started trying these after I took the Association of Migraine Disorders migraine toolbox course, which I highly recommend, to manage these patients better because we literally work in the nose for a living and we have cotton and lidocaine laying around the office. And so I started doing these, and the results were so impressive that I felt like I needed to get this out there. I felt this was a technique that really was pretty simple and right in the wheelhouse of most of the general otolaryngology colleagues that I have. I also realized that no one else was doing this after I did a pretty thorough literature search, and so I started doing some work to get some data, and I'll share that with you as well. So let's go through some slides. Let's learn how to do this because literally, if you watch these slides, you can turn around and try this tomorrow. So this is the bunch we see. We see the patients that think they have sinus, dizziness, and ear pain. Some of them come in with other things like tinnitus and transient other symptoms like phantom smells, clicking of the ears, hemifacial swelling, red ears, a lot of stuff. And these are migraine patients. But it's difficult because these are the patients that don't think they have migraines. The neurologists actually have an easier job. They see the patients who think they have migraines. They come in with headache, and they just need to actually then use their tools. But what happens is we wind up seeing these patients because they think they have sinus, they think they have ear infections that don't get better, and they think they have balance problems. Everybody's got the vertigo, and then they wind up getting a whole lot of workup and a whole lot of wrong treatment and spend a lot of money and time. And still, at the end of the day, we don't have a diagnosis because after their scans negative, their ENG's negative, or all pikes or maybe positive or negative. But anyway, the bottom line is they have migraines too, and we're stuck playing neurologist by trying to give them migraine medicines, and that's not in our forte, or sending them to a neurologist, which is oftentimes many months booked out at this point. So they're frustrated and they still don't believe you and they want to sign us that antibiotic again that works better. And so here we are. And patients and primary care doctors are just really not good at this. And it's not their fault because they don't really have a way to prove what's going on literally inside somebody's head outside of doing a CAT scan. That's usually not something people are doing for just routine visits at a minute clinic or urgent care. They're usually just giving them a Z-Pak and prednisone, and they get a little bit better because prednisone helps a lot of these things. But what we do know from a good study done in 2007, which was a study I quote frequently, is this sinus allergy migraine study, the SAM study that a lot of us actually heard in our residency training during Journal Club. It was a clever study where they took 100 patients who thought they had a sinus headache and actually did CAT scans on them and had them see neurologists, allergists, and otolaryngologists and find that only 3% actually had positive CT scans. And 78% of their primary care doctors thought they had sinusitis too. And so not only do they think they have sinusitis, another doctor told them they have sinusitis. So who's right? Well, these CAT scan is usually the judge and jury on these things. And of course, lots of times it's not when the patient went in to see that other doctor. So it's still sort of an unsolved mystery. But imagine if you could turn off the on button when they have that headache and then it goes away and their scan is negative. That's pretty convincing. And so that's a tool that I've been using a lot for these patients. And it's not their fault because this is what the sphenopalatine ganglion does. The Summit study showed this in 2004. They did a lot of evaluations of these patients. What they found is these patients basically had a lot of parasympathetic tone driven by pressure and a reflex from the sphenopalatine ganglion, and the whole ganglion gets lit up by whatever's going on, be it allergens, irritants, infections, and it creates a reflex back to the nose, makes it stop and run on the side of the headache. Plus, it also goes to the eye socket, causing eye symptoms, tearing, eyelid edema, redness. Uh, Frequently, these patients will have a unilateral corner syndrome, ptosis. And so what you do is sort of explain this stuff to them. But here again, then you're stuck playing neurologist again. And these are pretty miserable patients. If you looked at both these studies, these are both in the migraine severity scores in the sort of the miserable category. And these patients usually hurt not just over their forehead, but behind their eyes and in their maxillary V2 distribution. Their teeth actually hurt. So it's a pretty convincing sign because the clinical sign that most doctors use if they have sinusitis, does this hurt? Do your teeth hurt? And they will with migraines. And so they'll wind up getting a clinical diagnosis that's wrong. So, what is a migraine? Well, this is a diagnosis definition that was made as a research definition, actually, and it's probably a little bit too stereotyped and narrow. Recurring attacks, at least 5 attacks, fulfilling a criteria series, which means that this is still not well understood when you have to use these kind of criteria in my mind. Headache lasting anywhere from 4 to 72 hours is pretty broad. Two of the four characteristics, unilateral quality, which is not always there, pulsating quality, not always there, moderate to severe pain intensity. A lot of the older patients don't have much headache and they have migraine, just have dizziness, and aggravation caused by avoidance of routine physical activity. Well, that's non-specific. And then add on, they may have nausea and vomiting or photophobia and phonophobia, which is pretty classic with these patients, but still not always there. But they're not always accounted by another diagnosis as well. So here again, it's sort of a diagnosis of exclusion. And many don't fit this bad headache box. Migraines are stereotyped like asthma. Like you watch TV on an asthma patient that's dramatic, they can't get to the ER without their inhaler, they're going to die. It's it's that dramatic headache. But that's not what we're seeing. We're seeing patients that have older heads that are more tolerant to pain that don't have the headache they had when they're 20. These are patients in their 40s and 50s that are coming in with some headache and a lot of neck and jaw pain from basically worn out body parts that are triggering pain to the brain, which breaks the threshold. And so if you think of migraine, think of it more of an event and a syndrome rather than just a headache, because the headache may not necessarily be the prominent symptom or even be there. And so I think of it more as more like a seizure. There's this whole build up. There's a prodrome. There's neural excitation phase, which causes this sort of slowing down of brain processing, and particularly where it's located will cause neurologic symptoms sometimes, and that's the aura. And then you have the attack, where sometimes there's a loss of function. And there's a wave of inhibition at that point, and then that basically knocks out function sometimes. That's why people lose vision, get double vision, lose hearing, lose other functions during a migraine. Occasionally, some neurologically complicated migraine, and then there's the after postdrome, which is a little bit of a hangover where they just feel blasé. And then there's a period between the migraines called the interictal period. And many times the patients aren't well during the interictal period. They still have resting pain in various places like their necks or their jaws. in their foreheads. And during that time, their brain is just not working as well. They have some brain fog, slowing of processing speed, and a lot of other things that needs fast speed, like balance. And so, migraine, think of it more of as a threshold disease. You break a trigger of a brain's homeostatic state, you create an event. And that event creates a neurologic state of hyperexcitation where there's cortical spreading depression if it's a migraine. Alternatively, if it's synchronous firing, it's a seizure. So they're basically very similar, just one just goes off the rails. And the biggest triggers that we see are peripheral nociception. And that's things that cause pain to the brain from the head. And in the nose and sinuses is the pressure and inflammation in those areas. And in the other areas that trigger the pain is the nerves in the back of the neck that we really don't pay a lot of attention to, the occipital nerves. But they all go to the same circuit breaker, the trigeminal caudate nucleus, which I'll tell you about in a minute. And that's the key. Turning off all the on buttons in that circuit breaker will create a nociceptive quiet state. And once that's done, that's pretty powerful. And then whatever's inside the head, which is genetic, predispositions based on ion channels and neurochemical balances and acquired disease states that create these problems as well, like trauma and viruses. It drives that brain that's in a bad state to that condition. And there's a really great resource that you can refer to, a deep dive on this at the Association of Migraine Disorders. That's Rick Godley's website. It's a beautiful website. It's probably is the best migraine website on the web. And they've got great resources, posters, and a migraine toolbox course, which is coming out with the next version, which is a great, great deep dive into this disease process. So here's the strategy. Basically, you just got to get the brain fed, hydrated, and rested, which is giving it a homeostatic balance. Once you get there, then we just have to balance the neurochemicals that have either genetically gotten out of whack or over time from various conditions or neurologic or psychiatric problems to get back into a normal, balanced state. But that's difficult because it's hard to predict what drugs do in this realm in another person's head because even if you sort of know what you're doing, it may cause untoward side effects in other places to create a problem. So that's sort of a hot mess, right? And it's a bit of a guessing game because even then, if you even know what you're doing, the genetics of the enzymes that break these things down, the cytochrome P450 system is going to also oftentimes also have some control on how well these things work too. So I do a lot of gene site testing on these patients to actually see which drugs will work best for them if I start doing that. But I usually relegate that to the experts. The neurologists and psychiatrists are really good at that. But blocks, that's a third of what we should be doing, and they're sort of right in a wheelhouse of what we do. And then, trigger management, I would add that as a fourth strategy because that's sort of where we can really get after some things too by educating them of where these migraine pains are coming from by what when you block a nerve goes away. So blocks really could be the key. Think about it. If you could turn off the on button in a place where pain's coming from, you not only know, and it made the migraine and whatever else they came in for, like vertigo or tinnitus, go away. You not only know it's a neurologic process that can be turned off by blocking nociception, probably a migraine or something like it, and then it is not an end organ problem. It's not that they have a sinus infection or peripheral vertigo. They've got a neurologic condition that can then be targeted for therapy. Um, so why aren't these being done more? Well, not that many people do them, and they're also somewhat, outside the pill model, right? So insurance companies don't pay for them easy. Not that many providers do them, and people don't like needles. So here we are. But they do like a diagnosis, and if this could provide this kind of information that quickly in an expedient way, where they're not having to do brain Sudoku with various meds that take months to sort of know whether they're going to work or not, you can sort of shortcut all of that and also feel better in the process. So that sounds like a good idea, right? So let's think about that. So where are the targets? Is this something easy to do? Well, I think it is because we sort of work in the nose for a living. Sphenopalatine ganglion, we block all the time when we do sinus surgery. Anterethral nerve, same thing. The occipital nerves, here again, they're in the back of the head, but they're not hard to find. It's easier than finding studs in sheetrock. You can actually palpate these nerves in their locations, and they'll tell you if they're hurting. They're pretty hot to just mild palpation. So that's how I assess these patients. So here's the stars of the show. The anterior ethmoidal nerve is one that's always been sort of, I think, undervalued. It's in the front part of the nose, right under the nasal vault. And these patients get pressure in this area if their nose is narrow, particularly if the septum's deviated that way. And the pain usually correlates with the anatomy. And so what's being innervated by the anterior ethmoidal nerve? Well, it innervates the brow, the bridge of the nose and the forehead, but it also gets to the anterior cranial fossa meninges, and that's powerful. And that's why when you do a sphenocath or cat or any kind of SPG target and you miss V1, it misses an important target in my view. And V2, this is the classic one, and the reason why it's such a classic is because it does more than just circulate pain and a reflex to it. It has autonomic fibers going through that locus, and basically you can not only reboot pain, but also parasympathetic and sympathetic pathways by turning the neural circuitry, interrupting that neural circuitry in that area. So the problem is it's always been a difficult place to get to, right? It's underneath the eye socket behind the maxilla in the middle, really deep inside an area that's difficult to get to. So it's always been a target, but it's been, stereotypically targeted, but that's sort of a bit of a project, right? You have to use fluoro, anesthesia, there's risk, you can hit big vessels back there and cause bleeding, and it's not always easy to be sure you're in the right place because here again, that's through a lot of tissue. And then what about going to the back of the nose and using topical means? Well, that's a great idea because the nose absorbs medicine really well. And we're all wired the same way. The problem is getting there. And so if you're a neurologist, you don't work in the nose for a living, you don't have scopes. And if you're a primary care doctor, like Dr. Mizell, who came up with this technique with using catheters and got published in JAMA, use a Q-tip. But here again, it's still a blind poke. But what you're getting when you do this is not only pain in the posterior inferior nose and posterior inferior sinuses, but also the orbit and the maxilla in general, the whole V2 distribution, plus the posterior and middle fossa dura, meninges. Yes, if you get the meninges unactivated, that's going to really turn off a migraine, right? So that's why it's always been sort of the golden goose. Not only does it have the pain reflex arc, but it also has the autonomic aspects. And that's powerful because it does a lot of things for a lot of other aspects of neural processes when you interrupt that and reset it. And there's this whole aspect of sympathetic tone from migraines and in pain in general. It increases adrenergic tone and glutamatergic tone at the central nervous system level. And that creates generally an increased level of anxiety and triggering in these patients. And so they have a hard time using mindfulness or prefrontal cortex executive functioning. They're sort of stuck in a reactive phase and more anxious, and they start getting insomnia because they're generally starting to deplete their serotonin. So rebooting all this would be very powerful if we can get to it. The other thing that also happens is you increase pain from all these locations as you start increasing sort of the activation of that brainstem nucleus, the trigeminal caudate nucleus. And so I find is that pain in these areas, you can also see the resting tone by palpating the muscles in the TMJ circuit, the pterygoid, especially medial pterygoid, the base of the mandible is really tender. And that's usually from jaw clenching at night, and the posterior neck on the same side. Usually the V1, I mean the occipital lesser and occipital greater are usually pretty tender, and that gives you an idea. And the muscles are tender too because there's a high resting idle of their tone driven by pain. And then the occipital nerves. These are sort of the missing pieces of the puzzle, in my view. And we tend to ignore the back of the neck as otolaryngologists. And I think this is important to pay attention to in migraine patients because at least a quarter of the migraine pain is driven by the neck in a lot of these patients, especially the older we get. Here again, as we get older, we turn into a collection of worn out body parts, right? And this is usually by having eyes in the front of our head and hands below our eyes as higher level primates. We use our hands and by virtue of that, we look down at things, especially with the work we do. And then we add it on to that by burdening ourselves with computer screens and phones that we look down at bed. And we never give our neck a rest. And so the neck has to rest while we sleep. But a lot of the problems happen is from bad sleep position. Sleeping on a pillow is not high enough with ergonomic strain on the neck creates mad muscles pulling on nerves to create a lower firing threshold. It increases pain. So you'll see the lesser and greater occipital nerves are impinged upon by these major muscles in our neck that support it. The SCM traps the lesser occipital, and the trapezius traps the greater occipital, which actually goes through a little hole in the tendon. And so when these things are under tension, you hold tension on a nerve, it lowers its firing threshold, makes it easier to fire. And that's why when you palpate in these areas right over the beginning of the skull, the back of your head, you'll find that they're tender if that muscle group is overworked and overstrained and putting traction on them. So the key is to block these when they're involved because they're playing a role in keeping the trigeminal caudate nucleus at a higher idling threshold. So, and that is activated by the molecule CGRP, which I'll tell you a little bit about. And that's why all the new molecules, medications that are out there are targeting that molecule because it's pretty effective in keeping this from amping up. So, trigeminal cervical nucleus or trigeminal caudate nucleus, they're also called the complex, is sort of the circuit board that receives the nociceptive input from both the front and back of the head. And it's sort of inversely aligned in terms of its orientation front to back. V1 is actually at the bottom and V3 is at the top, and it correlates to the opposite in the back of the head. So you'll see mirror headache basically when you have V1 going the same place as the lesser occipital. It'll hurt in the front of the head, but also in the back of the head on the same side at the lesser occipital point. And where it originates as pain is probably where it hurts first. But once it gets it going, it sort of becomes like the mad toddler on the school bus that's sitting next to the other one and wakes it up. And next thing you know, by neurologically basically increasing the things like glutamate, CGRP, and nitric oxide, those things are involved in pain, substance P. And then you have this sort of goes to the thalamus and turns everything up a notch. Why? Because the thalamus is sort of the relay center that sends input to our awareness center and our emotion center and our cognitive centers to remember what that pain felt like. So you recruit emotion, a bad memory, and awareness. That basically becomes the loud toddler on the school bus. It basically takes all the attention of the brain, energy wise as well, and it makes it hard for it to function in things that need to function well quickly, things like memory and balance. And so that's why we see so much brain fog and balance problems in migraine patients, in my view. Then what we want to do is, well, how do we do this? I mean, I got this stuff laying around. What do I do, Dr. Abrams? Well, I figured out this wasn't that hard. We can just use this scope and this stuff and that stuff, and then let's make it happen. So we started doing this. I just tried on a patient that couldn't get into their migraine clinic because it was closed for COVID, and she was all dramatic. She was a cool patient that came in, dark sunglasses on, and wanted me to find a sinus infection to treat because she was miserable. Of course, I scanned her and scoped her, and it was fine. And I tried my first block by her just basically talking me into it. I just taken the migraine toolbox course, and I was sort of anxious to actually try this on myself. But since she offered, I said, let's give it a whirl. So I put cotton and lidocaine in these exact locations. Two up front because I figured it was easy to really make sure I got that one well. So I put two up there. You don't have to, but I think it makes sense because that way you got it good. Now, Dr. Godley likes to use cottonoids, and you're fine with doing that. And there's little cotton balls that are on a string that you can get from American Surgical, and I can give you a link to that too. But basically, you don't have to put a string on it, and you don't need to make these sloppy wet. So it shouldn't make the patient unable to protect their airway. So I don't really worry about aspirating these things now. I do swallow a cotton ball from time to time because I don't particularly like a string hanging out the front of my nose. And these are easy with a small piece of cotton, and that's really cheap. But the ones with strings aren't expensive too. And this should be inexpensive because why? We don't have a code for this, and we don't want to have to charge for the materials because nasal endoscopy is always covered. So that's the key of being able to do this on the fly. You can do nasal endo even on Medicare and Medicaid without a pre-cert, and that's plenty of reimbursement for a procedure that gives you and the patient this much productive information and help. So this is how I do it. Basically, if I suspect a migraine, I start off with a nasal block. That's easy. People don't like needles, and you're going to be looking at the nose critically anyway. I think patients with migraine typically have narrow nasal anatomy. You're not going to be able to tell the best you can about those patients without looking at the nose with a scope. Even non-otolaryngologists can probably use scopes, and they can probably do these. It just isn't unclear to me whether insurance would pay for them to do them. At any event, If the anterior block doesn't work, then you look at the neck nerves because those are easy to hit. It's easier than starting an IV, and I got the technique in here too, in case you're curious, so that you can complete the algorithm that's giving me the best results. So this is how I do it. I basically talk to them about this and give them some information about it. So while I'm prepping the nose with Afrin and lidocaine, they can actually learn about what we're doing. This is a little bit time consuming to explain, so giving them something to read while you're getting things ready is a great time saver. Now you can probably use tetracaine, you can probably use nisepinephrine, it probably doesn't matter. But you wait about 5 minutes, that's about all you need. And then meanwhile, you're going to be checking out the patient as well. Check the occipitals, check the pterygoid insertion point. That'll tell you sort of the TMD ear pain component. And then V1 and V2, which is the supraorbital and infraorbital nerve locations, which are pretty classic and they're usually tender. And you can check these at the end because they won't be tender if you've gotten a good lock to the location you're trying to block in that area. So that's useful, having something objective or semi-objective that you can actually compare to, because the patient has a control. They have the other side, and they have a place like the top of their head, which should not be tender with the same amount of pressure. So it should tell you if that patient is having discomfort. So, which indicates a lower firing threshold of that nerve. And so, literature to read on migraine is pretty easy. I got you a little cheat sheet, a little handout, and I can give you post migraine block information that I use for my patients, and that will help simplify things a lot. And then once you're ready, all you have to do is take a little small piece of cotton, and put 4% lidocaine, the stuff we have on our shelf, on it, and let it lay on a gauze long enough to allow the extra lidocaine to sort of elute out into the gauze so it's not sloppy wet. And you give the patient a lollipop or mint because it usually causes a bitter taste, and sometimes people get a little dramatic when their throat feels numb, and that seems to mitigate that. And then I just use a 0 degree small nasal telescope. I think cameras are really helpful and screens are very helpful because not only can you see what you're doing better, but the patient can too, and they can learn something. So all you need, you probably got, unless you don't have a telepack. But then, you can use a iPad, computer screen, laptop. You can set up your clinic without one of these expensive things for about $2,500. And I got exactly how and what to get if you want to do that. So here's the places that I tell every patient to assess when they have their migraine block wear off. And this is where you'll assess before and after so they can learn what you're doing, explain why you're doing that, so that they then can use this information themselves when their block wears off in a few months, that they can sort of see where it's coming from. So, you educate the patient and you prepare your cotton pledgets, and that's what I do. I put them in a kidney basin. I use a small micro alligator like I use for putting in pee tubes in the office. And these are some of the swedged pledgets that you can get from American Surgical. Here's a sort of information, sort of consent form as such. Tells you what you're doing, how you're doing it, what the risks and benefits are, and mainly the risk is the minute risk of allergy to lidocaine or Afrin, which we discover before we get to that point from the prep, and then the risk of potentially swallowing a small piece of cotton. And you can use swedge pledgets or cottonoids if you choose. They probably all work. I'm going to try pledgets on my cottonoids on myself. I've never tried that just to see if they're just as comfortable. In any event, these are the targets. Basically, underneath the bridge of the nose, at the head of the middle turbinate, and at the back of the nose, at the base of the middle turbinate, as far lateral as you can get it. Now, understand you may not be able to get it there on the first try because these noses are highly congested, but based on inflammation, or they wouldn't be in to see you if their head was hurting on that side. So this is where you do it. So basically, I place my anterior pledges, two of them up front.
Place it right up high in the nasal vault, about as high up as you can get it, just at the level of the head of the middle turbinate. And you'll place two of them in there because it's easy, and that way you can get a good block.
That's the septum turbinate, okay? And
Place it.
the sphenopalatine ganglion is not much different. All you have to do is, ride the top of the inferior turbinate underneath the middle turbinate and adjacent to the septum. You see she has a little spur there. And if you reach resistance and it's just a spur, wait, you'll have another chance. In about 10 minutes, you can actually push the pledget further to its to its location you need it to go. I call this a two-putt. And that allows you to actually get it where it needs to go when the nose is number and more decongested, because these patients are basically cadaveric. So I sort of, you know, push it as far as I can reach where I would expect the resistance to be for the sphenoid rostrum. I don't always see it actually getting there because you don't really need to. It's above the inferior turbinate in such a way that it's probably not going to go anywhere, especially if you can sort of gently sort of mash it against the back end of the nose so it just sort of sticks there. Because the nose has got a little bit of a sticky lining, right? And the wet cotton ball is sort of damp is going to stick there by capillary action pretty well. But it's going to allow the medicine to be delivered straight through the nasal lining, which is very favorable absorbing medicine. We know it probably absorbs through the lining in about 1 minute, and then it takes about a minute um, per centimeter for it to travel the axoplasmic flow to the ganglion. So it takes about 5 to 7 minutes to feel the blocks work, and I actually can feel my headaches start to melt away in that about that time frame. So when you're done, check and see what you've accomplished, and if they're not better, don't stop there. Don't try to achieve 100% because you usually can. You just got to just check your cotton pledges and check your occipitals to make sure if that's where there's still some pain located. So at the end, around 8 or 9 minutes, I usually go and ask my patient, are they still hurting, and ask where they're hurting, and I'll palpate the locations and see where things are still sore. And that'll tell you probably where you need to, check. In the nose, I try to improve my lie. I'll replace my pledges up high if it's V1, or just adjust them. And V2 usually have an easy poke at that point because the nose is almost cadaveric because you've aphrodized them and turned off cholinergic input at that point. So it's really pretty easy to achieve that block. And once you've gotten there, it doesn't take long. Usually between 30 and 60 seconds, I'll ask them, does it hurt anymore? No. I mean, it's pretty convincing. It's like that quick because you're almost there. You're just basically tapping in the putt, so to speak. So there's gotten a lot of, down regulation at the trigeminal ganglion. It just hasn't quite turned all the way off. But you got to remember some of the input is the TCN is coming from the back of the head. So if they're still hurting, particularly in the TMD point, that usually means the resting tone is still getting enough juice from here. And then you usually palpate on the same side where they're hurting here. It's usually where they're hurting. And it's usually all on the same side due to sleep positioning. So if there's still no better, I usually at that point it makes sense. It's got to be inside the head if it's not coming from outside the head. So an MRI and a neurologist is usually the next step. Now I got to have a CT scanner here, so if it's the thing they think they have sinus, because they can have both, I will scan their sinuses because that's convenient. With the occipital nerve blocks, here we go. This is not difficult. I mean, this is easier than finding an IV. I mean, because the patient will tell you where it is, because all you have to do is go to the 1/3 and 2/3 point between the mastoid tip and nuchal tuberosity, which are really easy to find on every patient. And then you just got to sort of basically, once you get close, just feel, and they'll be sore. There'll be a point where they're okay, that hurts, and you just mark it with a skin marker. At that point, you'll mark them before you do this so that you can check them easily, because it's usually behind the hairline we want to do your injections, and you don't want to keep mashing and fishing around because it just takes time and it's just annoying. So once you do that, then it's just basically simple. I use buffered lidocaine first, just like you would do when you're starting an IV. You don't want to create nociception when you have a migraine patient because that's what's going to trigger more pain into the ganglion. So if you use buffered lidocaine with a 30 gauge needle, it hardly feels like anything's going through the skin. And just the burn of the lidocaine buffered is a whole lot less and a whole lot quicker. Within 20 seconds, these patients are numb enough to actually traverse that same pathway with a 25 gauge needle and then deliver bupivacaine, usually anywhere from 3/4 to a whole cc is all you need, of anywhere from half to 1/4%. It doesn't have to be that exacting. It really is pretty forgiving as a procedure and durable. So once we've turned off the trigeminal caudate nucleus juice, that's a very powerful thing because these are 3 points that are really important to consider. One, neurotransmitters have millisecond half-lives. That's powerful because it doesn't take long for those neurotransmitters to basically that are responding to this pain to be reabsorbed and go away. And once that happens, that means the pathways up and down get rebooted. They have a chance to restart. This is a control alt delete for your computer essentially. And upstream, that's the brainstem and thalamus and all the things that it does. And downstream, it's the sympathetic and cervical pathways. But, keep in mind there's a pathway convergence that's creating this pain from the back and the front of the head. And if you don't do both, a lot of times you're not going to get a complete nociceptive quiet state, which is our goal when we're doing blocks, is to basically turn off the pain coming from the head and neck. And what that does is actually modulates pain elsewhere. Patients' back pain and shoulder pain actually be better after this too, because there is a limited amount of pain controlling pathways in the brain that are tied up actually dealing with this. And this is not really anything useful. This is non-helpful pain. And basically, then it allows what's left to be able to manage the other things. So, these patients will have other things as well. They'll come in with odd ear symptoms, transient tinnitus, hearing loss patients with sort of that, patient that thinks they have an auditory processing disorder. I'll block them and then all of a sudden that'll get better. Hyperacusis patients, actually, I'll jingle keys by their ear after I do a block. The patients that tell you have some drainage or something crawling around the ear and ear looks fine. I said migraine are typically, and they usually have TMJs, all that stuff too. And myoclonic tinnitus here again, those are dysregulated middle ear and palatal muscles that really a lot of tremors actually get better with this. I've seen patients with benign essential tremor, the tremor get better after a block. And it's because it probably just clears the central nervous system sort of, slowing to allow it to be more efficient in more of a general sense. And then olfactory symptoms, a lot of phantom smells will come in. I'll block them. I'll go away for months. And also their low level of base smell will actually come back. So it's a really valuable tool for these patients that are pretty miserable with their loss of smell after COVID. And so I found that to be as useful as anything I've done. And then vascular symptoms, hemifacial redness, the red ear, that I used to think was relapsing polychondritis, it's just a migraine. And then just autonomic symptoms. These patients, I've had some hyperemesis patients. The POTS patients will get better. The patients that have, you know, I've used it on a pregnant woman with Bell's palsy. I've also used it on with head pain, and I also had zoster, and their hyperemesis got better. You can see hot flashes get better. So dysautonomia is really rebooted with this, and this is pretty good stuff. I mean, it really works. If you look at, I had a pile of data which had my SPG AE around 73%. That was on 105 patients. Then we looked at it with another phase of data, and we're now up to 87% because we've just gotten better at it. And your learning curve, learning these pearls will probably be better because that's, learning how to improve my lie and check my points is really what's got me there. And of course, not leaving out the occipitals. Occipitals are so easy. So I just have already pre-drawn up syringes with buffered lidocaine and marcaine ready to go. And, that makes life just very simple. And what you get out of this is worth the bother. 15 weeks of duration. I mean, even in my pilot study, which was 13 and a half, it's still on par with Botox, and you don't have to worry about insurance coverage because you're not doing something that's not covered. The occipital blocks are covered just with posterior neck pain. Don't use anything specific like occipital neuralgia. That's what they have insurance scrubbers to block. Posterior neck pain is just, you're just giving it a shot. And Medicare, Medicaid, commercial insurances have not had any problem. And if you add on the occipitals, not only do you get a block percentage-wise efficacy immediately, but also duration as well. We seem to get another month out of an occipital block in terms of duration, and it seems that it's just a better thing to do, and additional blocks actually last longer for a multitude of reasons. I think the brain is now in a much better homeostatic state from not being exhausted from pain, and the patient is actually playing their game better too. So you know, other facial pains, these work. Cluster, trigeminal. We already know cluster headache's been indicated for SPG blocks for a long time, but also other neurologists. I've had my zoster and postherpetic Bell's patients pain get better, and so does their dizziness also. TMD patients, myofascial neck pain, tension headache. This is just the afferent loop. Yeah, I don't know. I mean, because maybe that's just all part of the migraine itself, is just the muscle tension coming from the TCN. And so I think this is stuff we still have to figure out. I think the brain's a fascinating, final frontier, and and I think we're still learning a lot about it. So my conclusions is, you know, migraines, they imitate a lot of the conditions we see, particularly sinus balance and ear conditions, and we need something better than just trying meds. Although I do advocate you trying them because I think they're not that hard to do. And I think, listening to Michael Teixeira and the rest of the folks, Mark Maley and the rest of us that try to teach about this, that's actually a little bit more challenging because it's sort of a long project. This makes it quick. And we have scopes and we have cotton and lidocaine sitting right here in our office. And lidocaine and marcaine aren't hard or expensive to get either. And so when you do these, they're very effective. And they're effective not only in terms of making the patient feel better, but also telling them a lot more about what's going on as a diagnostic tool, particularly for the dizzy patients. The first thing I do after a Hall pipe test is I get them to block. And then finally, about 80 or 90% of the patients you're seeing that dizzy have some migraine component these days. And then the advantage is that we can see what we're doing and we should be doing this. This is the ball we should be running with because we are the people who work in the nose for a living. And this isn't hard to do. Seriously, we're not having you operate in the posterior sphenoid. We're actually just having you put cotton inside the nose, like prepping a nose that we do at the beginning of the case while we're talking about our day. This is also something that, is an office procedure and it doesn't have to require a pre-cert, although if you don't have time, you could set aside a designated time and you can delegate this to your advanced care providers, my PAs who does my blocks, and actually taught my medical student how to block me. This is not difficult. And then finally, this is not a needle. There's no injections unless you're doing occipitals, and even then, you're not using a lot of materials. We're not worried about anesthetic toxicity by doing these things. Minuscule amounts of local are being administered to these patients, a lot less than we do when we just do a retuned septoplasty. So this is not a dangerous procedure in any way, and the cost is minimal. So it's compelling. So that's why I felt like even at this stage of my career, I wanted to sort of do a little research, contribute to the field, and I think this has been something that's contributed a lot to my practice and the joy of seeing patients because these are the happiest patients you'll see when they leave feeling not only better, knowing what they've got, and just a feeling of calm. Because when you do a sphenopalatine block, you actually bring up their serotonin and drop their sympathetic and glutamatergic tone immediately. The feeling of calm, unless you get these yourself, it's hard to explain until you've actually had one. And so, if you do have migraines, a lot of patients do nowadays because of COVID, I would highly suggest that you try it on each other. See if you can actually practice that way because this is not something that's that uncomfortable and difficult to do. So thank you for your time. And if you have any questions, you can call my migraine trigger. That's my little girl. At Christmas, it looks like she was having a mug shot at school. And so I made this as a Christmas card. And then to learn more, I've got a training video link here that you can use. I'll update it for the slide and patient video that we've actually made for them to watch, and also a self block technique using Q-tips and or cotton and topical lidocaine that if you can talk to your local pharmacist, they oftentimes will play nice and let you write a prescription for your patients as long as they know what you're doing with it. So if you have any questions, send me an email. Go to our website. We're updating that every day. And also check out Rick's site, Migraine Associated Migraine Disorders and the Myo Society. Get involved. There's a very active forum on there. We just need to get more active so we can discuss interesting cases and get better at doing this. I look forward to doing a multi-center clinical trial on midfacial migraine and trying to get a randomized placebo control study behind us too to allow this to have greater literature uh, backup. So thank you for your time and do these.